Hello, hello, hello. Hello, hello. Okay, good evening, everyone. I hope I'm audible. Can you just give me a quick thumbs up to check whether the audio and video is fine? Yes, anybody who can just give me a quick thumbs up so that we can start. You can put it into the chat. Please put the comment into the chat. All right, so it's a doubt solving session for the radiology. Okay, yes, thanks Furkan. Thank Mustafa. How are you doing? So it's a doubt solving session for the radiology related queries. I hope you people are reading well and preparing for INI CT November 2022 or an exam in 2023. We are really not sure whether it is gonna be NEET or next, but the radiology related questions are gonna be remain same the way that we saw in the NEET PG 2022. That means where radiology will be a part of question and it's more of clinical scenarios. If I see this here, we have seen a lot of contrast based images. So do let me know if you have doubts. If you do not have doubts, then I would like to teach you a topic. So I'll just wait for 2 minutes. If you have any doubt across left and right, anything into the radiology, please share it with me and I would be happy to answer it. If you do not have a doubt, let me know so that we can start and we can talk about a topic. Anything left and right, anterior, posterior, and there are 6 directions: left, right, anterior, posterior, superior, inferior. Any doubt anywhere, let me know. I will try to answer. If you don't, then probably I will be discussing a topic with you. All right, so if there are no doubts, okay, so let me just show you certain images and let us just take you through. If I just talk about this year paper pattern, as I have spoken to a lot of you, is that the paper pattern is basically there were around 24 questions that I say were based out of radiology out of 200 questions. So that means more than 10%, 10 even, more than 10% of the paper was linked to the radiology. 8 questions were core radiology, 8 questions were integrated, and 8 questions where the radiology was a part of the question rather than having a complete question, a part of the question. Okay, so now let us see some of the images. Um, just give me a sec. So anybody who can tell me what is the image that I am showing you? There is one question that the examiner is very, very fond of asking is identify the image. So I hope all of you can identify what is this image. So this is nothing but the CT scan of the brain. CT scan of the brain. What is this black color structure that you could see over here? Now this is ventricular system. This is ventricle. A very common question that I have seen a lot of time people ask is what is the nomenclature used for it? So please remember, if you see something as black in the radiology, I will call it as hypo. If you see something as white on the radiology, I will call it as hyper. Black is hypo, white is hyper. Since it's a CT scan, it will be dense. So the terminology for the CSF here would be dense. So it is hypodense. Hypodense. Okay. What is this structure which is adjacent to the CT over here? Sorry, adjacent to the ventricle. Anybody who can tell me what is the structure adjacent to the ventricle? Now this structure is head of caudate nucleus. This is head of caudate nucleus. Anybody who can tell me a common disease which causes atrophy of the caudate nucleus? A common disease which causes atrophy of the caudate nucleus. Anybody? Huntington's chorea. A common disease which can cause atrophy of the caudate nucleus is Huntington's chorea. And Huntington's chorea. Now, since there is an atrophy of the caudate nucleus, the support from the lateral wall of the lateral ventricle is lost, and the ventricles appear in this shape. And ventricle appears in this shape, and this is called as box-car ventricle. Box-car ventricle. So if somebody asks me box-car ventricle is a feature of anybody? Box-car ventricle is a feature. Boxcar ventricle is a feature of Huntington's chorea. Okay. This triangular shaped structure, apologies for it. This triangular shaped structure that you could see over here is lentiform nucleus. This is called as lentiform nucleus. Lentiform nucleus. And if somebody asks me, what are the two important components of the lentiform nucleus? The two important components of the lentiform nucleus are globus pallidus and putamen. Globus pallidus and putamen. Now the point to be noted is globus pallidus is medial, putamen is peripheral. If somebody wants to remember it, the easiest way to remember it is P for putamen, P for peripheral. P for putamen, P for peripheral. It is to be noted that the putamen is the most common site of hypertensive bleed. Putamen is the most common site of hypertensive bleed, whereas globus pallidus is commonly involved in a disease which is called as Heller-Warden-Spatz disease. Globus pallidus is involved in Heller-Warden-Spatz disease when there is deposition of the iron over there, which is called as eye of tiger appearance. This structure that you could see over here is thalamus. Thalamus. It is to be noted that the involvement of bilateral thalamus is a common feature of Japanese encephalitis. Involvement of bilateral thalamus is a common feature of Japanese encephalitis. Okay. All right. Now, anybody who can tell me what is this imaging investigation? So, if the cortical bone is black, this will be MR. If gray matter is gray, white matter is white, and the CSF is black, this will be T1 weighted MRI. This is a T1 weighted MRI. Whereas what is this? Now the CSF is white, gray is white, white is gray. So this will be T2 weighted MRI. T2 weighted MRI. Okay. Alright. Anybody who can tell me what is image number 1 and what is image number 2? What is image number 1 and what is image number 2? Yes, Denny, I will talk about MAS and KVP. I'll talk about it. But I'm waiting for you to give me an answer. What is image number 1 and what is image number 2? Image number 1 and image number 2. What do you think are these? So the moment you see the vessels, remember the simple rule. The moment you see the vessels, this is angiography. The moment you see the vessels, this is called as angiography. And a lot of people get confused between different kinds of angiographies. So I'll try to tell you a very, very simple way to remember all the angiographies so that if you get an angiography based question in the exam, you do not get confused. Okay. So let me just quickly take you through some of the common, just give me a sec. angiographic images. Okay, so please remember this. It's a simple rule. First of all, if you are seeing a cross section, please understand this. In a cross section, this is called as line versus dot principle. Line versus dot principle. Now, what's a line versus dot principle? If it's a vertical vessel in the body and I take a transfer section, it will be seen as a dot. If it's a horizontal vessel and I see it in a transfer section, it will be seen as a line. So always remember this line versus dot principle. That means if there is a vertical vessel that is present and you take a transfer section, it will be seen as a dot. If it's a horizontal vessel and you take a transfer section, it will be seen as a line. So first of all, if I ask you on a transfer section, let me see who answers it first. Renal artery will be seen as a line or a dot on a transfer section. Renal artery will be seen as a line or a dot on a transfer section. Renal artery is a horizontal vessel, so it will be seen as a line. IVC. IVC will be seen as a line or a dot on a transfer section. IVC is a vertical vessel, so it will be seen as a dot. Dot or circle, it's the same thing. Similarly, aorta. Aorta will be seen as a line or a dot. Aorta will also be seen as a dot. The IVC will be on the right side. Aorta will be on the left side. Okay, good. Common carotid artery. Yes, who tells me first? Common carotid artery will be seen as a line or as a dot. Common carotid artery will be seen as a dot. Okay. MCA, middle cerebral artery, will be seen as a line or as a dot. Middle cerebral artery will be seen as a line or as a dot. It will be seen as a line. By line, internal carotid artery is a vertical vessel and then it gives two branches. Anteriorly goes ACA and laterally goes MCA. Okay. All right. So the point to be noted is that whenever you have a problem in remembering or in understanding that which vessel sees like that, that is how you can see it. Okay. Now, if you get an angiography, how will you identify that what is the type of angiography it is? Okay. So obviously, first of all, you have to understand that what kind of vessels are being shown to you. If it's an abdominal vessels and you see a vessel which is going like this and going like this, that means there is a celiac artery which is giving the common hepatic artery and the splenic artery. If this is an aorta and you see a vessel which is pointing downward like this, this will be a superior mesenteric artery. So these are the two one that the examiner asked: celiac artery angiogram and an SMA, superior mesenteric artery angiogram. Okay. All right. Next. Now, if you get this image, obviously you can identify that this is the circle of Willis and this is the neck angio. This is the neck angio. Okay. Now, the point to be noted is what are what angios. So, it's a simple rule and it's a cheat code. Remember, if the black color vessels are shown, it is almost always a catheter angio. If it's a black color vessels are shown, it is almost always a catheter angio. If the white color vessels are shown, it will be CT or MR angio. If it's a white color vessels are shown, it will be a CT or an MR angio. Okay, that's the simplest rule. That's the simplest law. If somebody asks me, can I get a white vessels in a catheter angio? Yes, my computer has a capability to change. Can I see a black vessel in a CT or an MR angio? Yes, my computer has a capability. But as a rule, if these are subtracted images, remember that rule. If these are subtracted images, what is the meaning of a subtracted images? When the background of the image has been subtracted. If it's a subtracted image, as a rule, the catheter angiographies are shown with a black color and CT angiographies or MR angiographies are shown with a white color. If somebody asks me, can we differentiate a CT or an MR angiography? Answer is no. It is very, very difficult. I will say at a PG entrance examination level, practically not possible to differentiate a CT angio from an MR angio. All right. Anybody who can tell me what is the name of the investigation? Some of you will be finding these questions to be very, very simple, but please remember, this is what is expected in the radiology from you in the exam. That this was a question that has been asked in the past. that tell me the name of the investigation. So I don't think the moment you see the probe, you have a challenge. You know that this is an ultrasound image. Let me go one step up. Anybody who can tell me which body part has been shown to you? Which body part has been shown to you? So this structure that you could see is liver. This structure that you could see, yes, anybody who can tell me, is it gallbladder or kidney? Is it gallbladder or kidney? If this is liver, what do you think? It's gallbladder or kidney? What do you think is this? Now please remember, had it been gallbladder, you would have seen a structure which is jet black from inside. Jet black from inside. But if you see a structure like this with central white area like this ought to be kidney. This ought to be kidney, and this white area is renal sinus fat. This white area is renal sinus fat. Okay, renal sinus fat. Had it been gallbladder, as I told you, it will be completely jet black from inside. Okay. Now, anybody who can tell me, apart from renal sinus fat, what could be so white in the center of the kidney? Anybody who can tell me, apart from the renal sinus fat, what could be so white? What could be so white in the kidney? Stone. It will be stone. Okay, it will be stone. But now the question is, how will we differentiate if the stone and fat both are white? How will we differentiate? So please remember, stone will show acoustic shadow. Stone will show acoustic shadow, whereas renal sinus fat will not. Stone will show acoustic shadow, whereas renal sinus fat will not. Okay. All right. Anybody who can tell me, this is liver, this is kidney. The space present between the liver and the kidney is called as what? The space present between the liver and kidney is called as what? And what is the clinical significance of that space? What is the name of the space between the liver and the kidney? And what is the clinical significance? This is called as hepatorenal pouch. Hepatorenal pouch. Hepatorenal pouch, also called as Morrison's pouch. Hepatorenal pouch, also called as Morrison's pouch. If somebody asks me what is the significance, I will say hepatorenal pouch or a Morrison's pouch is the most dependent part of the peritoneum in the supine position. Hepatorenal pouch or Morrison's pouch is the most dependent part of the peritoneum in the supine position. Okay. Anybody who can tell me what is the name of this investigation? What is the name of this investigation? Yes, anybody who can tell me, quick answer. What is the name of this investigation? This is M-mode cardiac ultrasound. M-mode cardiac ultrasound. This is an M-mode cardiac ultrasound which is done to look at the valvular morphology and motion. M-mode cardiac ultrasound is done to assess valvular morphology and motion. Okay. This was this year NEET PG MCQ. Very, very simple image, but very interesting MCQ. Anybody who can tell me what is the name of the investigation? Yeah, that's a Doppler scan. Very good. So that's a Doppler. Now, who will tell me what is this pattern known as? What is this pattern known as, and what are the vessels in the body which show this pattern? In this year, the NEET PG, the only question that was asked is what is the name of the investigation. But now you have to tell me what is the name of this pattern. The name of this pattern is triphasic pattern. Triphasic pattern. Triphasic pattern. And please remember, it's a normal pattern of peripheral arteries. It's a normal pattern for peripheral arteries. Triphasic pattern is a normal pattern for peripheral arteries. Okay. Alright, some more images for you. Barium studies is also a very common topic that examiner asks. Okay, before that, let me just take some of the questions that you have asked. Alright, so बच्चे पिट्यूटरी एडिनोमा की अगर हम बात करें ना उषा, so see pituitary adenoma की localization, if somebody asks me, dynamic contrast enhanced MRI. Specifically, if I'm talking about a microadenoma, dynamic contrast enhanced MRI is the investigation of choice for the localization of microadenoma, and microadenoma shows delayed enhancement. Dynamic contrast enhanced MRI is the investigation of choice for the localization of pituitary adenoma, and microadenoma shows delayed enhancement. Okay, one. Let me take the other doubt that somebody had. Okay, MAS and KVP. So please remember, if I just talk about in a brief about these two points, please remember. देखो, KVP changes the penetrating power. Please understand this. MAS changes the background blackening. Okay. KVP changes the penetrating power and MAS changes the background blackening. Because KVP changes the penetrating power, now the point is it changes the color of the image. It tells whether the image will be less white or more white. Whereas MAS is changing the background blackness. So it is changing the density of the film. What will be the background blackness? Okay. Now, if I get a muscular patient, please understand, a muscular patient or a heavily built patient, examiner is trying to say that what should I do so that I can increase the penetrating power of the beam so that the beam can pass through that. And in that case, I need to increase the KVP. I need to increase the KVP because KVP increase will lead to increase in the penetration. However, if the examiner asks how you can increase contrast in an obese patient, increase contrast in the obese patient, see, contrast is inversely proportional to KVP or directly proportional to MAS. So if I want to increase the contrast, I have to either decrease the KVP or increase the MAS. But now since the patient is obese, I cannot afford to decrease the penetration, and that is why this cannot be the answer, and hence the answer is this. Okay, so that is what is a play with the language, and according to that you have to pick up the answer. Understood? Yeah, so supranuclear, progressive supranuclear palsy shows hummingbird sign. Hummingbird sign. All right. नीट और नेक्स्ट, बच्चे देखो, मैंने बहुत डिस्कशन करा इस चीज के ऊपर ना, थोड़ा सा बता देता हूँ. Presently the government is becoming slightly rigid because for the last 2 years there has been lot of ups and downs with the exam dates. So this time they have been very rigid with the dates. If you look at it, there have been lot of pressure on the government for changing the NEET PG, and more than that for changing the NEET UG exam date. But they did not change the date and the exam happened on time. So I was speaking to some of the people, and the conclusion that I have got is that the government is trying very hard to have the exam on the dates that they are announcing. They are trying their level best to conduct the exam as next in the next year. However, I feel that if they have to change the pattern like that, because whether it is in Hindustan Times or whether it is in a newspaper, it does not matter. What matters is what government directly announces. I feel that they should give an announcement at least 6 months in advance. Specifically, the biggest point that I feel about the next is the final year MBBS student, because they will be in a soup. For a student who is a post-intern, or for that matter who is an intern, it does not matter whether it's NEET or next, because ultimately the exam pattern is going to remain clinical. But for a final year MBBS student, it matters a lot, because they are in a soup whether they have to write a PG entrance exam in this year or whether they have to write a PG entrance exam after 1 year. Okay, so I feel that the government should give a clarity very, very soon on this particular point. Doing a pre-internship exam in the January for a PG entrance exam is not the correct thing that the government should do. I feel that majority of the time, unless there is a disaster, government doesn't take a very, very wrong step. So that is how the scenario is. But yes, something concrete, if it will come, definitely I'll inform you. Don't worry about it. Till then, keep reading. Yes, Bacha, I can tell you. Okay, differentiation, hyperlucency, and opacity. Yes, I can tell you all these points. I was just discussing the images because there were no doubts. Now, since I've shown you these images, what is this? Barium swallow, because I can see esophagus. What is this? Barium meal, because I can see the stomach. What is this? Barium meal follow through, because I can see the small bowel loop. And what is this? Barium enema, because I can see the large bowel loop. Okay, so now let us take your doubts. Okay, so देखो, lucency and opacity, interesting point. In the radiograph, it's a very interesting, a very, very interesting thing. Please understand. In a radiograph, the two terms that we use are lucency and opacity. Understand this. Lucency and opacity. Lucency means black. Opacity means white. Lucency means black. Opacity means white. Okay. What gives lucency to a radiograph? Air. What gives opacity to a radiograph? Bone or soft tissue. Bone or soft tissue. Okay. Now, increase in the air will lead to increase in lucency, which is called as hyperlucency. Increase in the soft tissue will cause as called as opacity. Decrease in the air will lead to decrease in the lucency, which is same as increase in opacity. Decrease in the soft tissue will be same as decrease in opacity, which is same as increase in the lucency. That's all. Rather than mugging up those big tables, that is how I'm going to remember. So that means, what is the cause of hyperlucency? Simple. Very, very simple. Either it is increase in the air or decrease in the soft tissue. What is the cause of opacity? Again, very simple. Either it is decrease in the air or increase in the soft tissue. So simple. It's a simple logic. That's all. Okay. Triphasic pattern. All right. Sorry for it. Triphasic pattern. देखो, hemangioma. So every focal lesion in the liver has a specific pattern. Every focal lesion in the liver will have a specific pattern. Just give me a sec. Hemangioma क्या करेगा? Please situate. देखो, hemangioma क्या है समझो. Hemangioma is a vascular tumor with what you can say is a disorganized blood vessels. You can broadly say disorganized blood vessel. So as soon as you inject the dye, you can say there are pool of vessels that are present. Imagine it's a pond filled with water, and now you have taken the colored water from it. So colored water is started entering into the pool like this. Colored water will start entering into the pool like this. So what is happening is that once you take an arterial phase, it shows peripheral discontinuous nodular enhancement in arterial phase. Peripheral discontinuous nodular enhancement in the arterial phase with centripetal filling. With centripetal filling. What is the meaning of centripetal filling? The blood will start getting collected here and slowly will move towards the center. So this is called as centripetal filling. So peripheral nodular enhancement in the arterial phase with centripetal filling. Centripetal filling is the hallmark feature of hemangioma. Okay. What happens in HCC? Normally, 20% of the hepatic arterials of the blood is coming via the hepatic artery, whereas 80% of the blood is coming via portal vein. This happens in normal liver. In HCC, 100% of the blood is coming via hepatic artery. 100% of the blood is coming via hepatic artery. So if somebody asks me, I will say arterial enhancement and portal venous washout. Arterial enhancement and portal venous washout is a hallmark feature of hepatocellular carcinoma. Arterial enhancement and portal venous washout is a feature of hepatocellular carcinoma. Hepatocellular carcinoma. So as far as exam is concerned, these are the one that I want all of you to be aware of. Third, as somebody has asked, is FNH. FNH is a focal nodular hyperplasia. Focal nodular hyperplasia. What I want you to remember is a very important point about the focal nodular hyperplasia is the presence of central scar. Presence of central scar. A very important point about the focal nodular hyperplasia that I want you to remember. Okay. Now, FNH usually shows a very bright arterial enhancement, very homogeneous arterial enhancement, but non-enhancing central component, which is a central scar. But I don't think that for a PG entrance exam, we should go into the details of FNH or a fibrolamellar variant of HCC and all. Hemangioma and HCC are the one that I feel that you should be aware of. Okay. Counseling gonna happen. Yeah. Counseling is another challenge that is there. I feel that the government has asked for some data from the medical colleges because they wanted to get that 50% seat, and the last day to submit that data was 16 July, and the 16 July is already over. So we should expect the announcement of the counseling soon. Okay. देखो पोस्ट ऑपरेटिव बाइल लीक में ना बहुत सारी इन्वेस्टिगेशंस कर सकते हैं. देयर आर lot of investigations that can be done in the post operative bile leak. I feel that it's totally dependent on the choices that are given. If somebody asks me an ERCP is given in the choice, then that will surely confirm that what is the site of the leak, and it will also help you to put a stent at that point of time. MRCP has also been found to be very useful. I will say that all that specifically depends on what kind of choices that are given, and according to that we have to pick up the answer. But if ERCP is given in the choice, then probably I'm gonna go with that as the answer. Okay, some of the nuclear scans have also been used, but for the last so many years, the use of them have been limited. MRCP images I can show you, bache. I have some MRCP images. I got it. Okay. You can see these images. Anybody who can tell me what is this image? देखो क्या है ये? You can see common bile duct. You can see pancreatic duct. And when you don't see anything else, this is MRCP. Okay. Whereas if you see an endoscope, that is called as ERCP. If you see a tube in the center, then that is called as T-tube or percutaneous cholangiography. T-tube or percutaneous cholangiography. The top three images are normal images, whereas in the bottom, I have tried to show you two abnormal images. What is this? See the intrahepatic biliary radicals here and see the intrahepatic biliary radicals here, and tell me what is the difference and what do you think is the answer. You can see dilatation and constriction of the intrahepatic biliary radical, and this is what is anybody who can tell me what is the answer? This is PSC. What is PSC? Primary sclerosing cholangitis. That's a typical image of a primary sclerosing cholangitis. Whereas this is a very, very simple image. Anybody who would like to take an attempt on what is the image that has been shown to you over here? What is this? I can see a dilated CBD. If I see carefully, I will see two filling defects in the distal end of the CBD. A two filling defect in the distal end of the CBD with proximal dilatation. You are dealing with choledocholithiasis. Choledocholithiasis. It is to be noted, if I would have seen the CBD dilated and I would have seen the pancreatic duct dilated and no stone, then I would have called it as a double duct sign. And who will tell me first? Double duct sign is a common feature of which disease? Double duct sign is a common feature of which disease? Double duct sign is a common feature of periampullary cancer. Double duct sign is a common feature of periampullary cancer. And anybody who can tell me what is a typical pattern of jaundice that is seen in periampullary cancer? A typical pattern of jaundice seen in periampullary cancer. A typical pattern of jaundice in periampullary cancer is waxing and waning pattern of jaundice. Waxing and waning pattern of the jaundice. Okay. All right. Let me make another. If I make a filling defect which is in linear position like this, a linear filling defect within the ERCP or MRCP is a feature of what? Anybody who can tell me? A linear filling defect in the ERCP or MRCP is a feature of? A linear filling defect, if an intervention has been done, is secondary to a stent. However, if there is no history of any intervention, then it is secondary to a biliary worm. Yes, Siddiqui, you are correct. On and off pattern of jaundice or a waxing and waning pattern of jaundice. Yes, very good, Anu. Correct. Yes, worm is correct, Akhil. Correct. Alright. What was the other doubt that you asked me? MRCP, I have already shown it to you, bache. Iohexol, yes, that I can tell you. Dekho, iodinated water soluble contrast agents are divided into two groups, ionic and non-ionic. Ionic and non-ionic. Ionic is, if it will go into the water, it will break down into cation and anion. If it will go into the water, it will break down into cation and anion. That means each ionic molecule will give me two particles. Whereas non-ionic will not break down and it will give me only one particle. Ionic is further divided into monomer and dimer. Monomer and dimer. Similarly, non-ionic will also divide it into monomer and dimer. Okay. Monomer. Monomer has got a structure like this. That means got one ring with iodine at alternate position. Whereas dimer has got a structure like this. It has got two rings with iodine at alternate position. Whenever there will be monomer, it will have one ring. Whenever there will be dimer, it will have two rings. And every monomer will have 3 iodine, every dimer will have 6 iodine. If it's an ionic compound, it will have carboxylic acid group. If it is non-ionic, it will have alcohol group. Alcohol doesn't break down, and that is why alcohol remains as one particle, and ionic COH break down into CO minus and H plus, and that is why it's seen as two particles. अब देखो iodine particle ratio कितना आसान है. iodine particle ratio is the number of iodine to number of particle. 1, 2, 3. Since it's an ionic compound, particles are 2. Ionic dimer 1, 2, 3, 4, 5, 6. Ionic particle has to be 2. Non-ionic monomer 1, 2, 3. 3 particle 1, 3 is to 1. And non-ionic dimer 6 is to 1. So 3 is to 2, 6 is to 2, 3 is to 1, 6 is to 1. Example क्या है? The example of this is urographene or ditrizoate. Example of this is ioxaglate. Example of this is iohexol. An example of this is iodixanol. Iodixanol. That's all. So these are the important ones that you need to be aware of. Okay. All right. Any other doubt? Any other doubt? Okay. Any other images that you want to see? Tell me. I have a lot. I have lot to show you. You just let me know if there is specific image that you want me to show you. Okay. Let me show you some IVP images. Can you quickly tell me what is the diagnosis of this image? What is the diagnosis of this image? This is horseshoe kidney. Can you tell me what is the diagnosis of this image? What is the diagnosis of this image? So this is, please remember, this is crossed ectopia. The commonest mistake that a lot of people do is they will think that it's a duplicated system. Since there is no kidney on this side, this is an ectopic kidney which has moved on to this side. This is not a duplicated system, and this structure is a duplicated system. Whereas you see one ureter on this side and two ureters on this side. One ureter on this side and two ureter on this side. And anybody who can tell me from a surgery knowledge what is the law that is applicable to duplicated system? Which law is applicable to the duplicated system? Wiegert Mayer law. Wiegert Mayer law. Now, what is the Wiegert Mayer law? Yes, anybody who wants to tell what is the Wiegert Mayer law? Wiegert Mayer law is, in a duplicated system, the upper pole moiety ureter is ectopic. In a duplicated system, the upper pole moiety ureter is ectopic and open distal and medial to the lower pole moiety ureter. Wiegert Mayer law says that in a duplicated system, the upper pole moiety ureter is ectopic and open distal and medial to the lower pole moiety ureter. The upper pole moiety, U for upper and U for ureterocele. Upper pole moiety ureter is associated with ureterocele, and the lower pole moiety ureter usually has VUR. The upper pole moiety ureter is usually associated with ureterocele, and because there is a ureterocele, it is obstructive. There is a selective hydronephrosis of the upper pole moiety ureter. Because there is a hydronephrosis of the upper pole moiety ureter and the upper pole of the kidney become non-functioning, the middle and lower pole calyx becomes like this, and this is called as drooping lily sign. This is called as drooping lily sign. Drooping lily sign. Okay. All right, anybody who can tell me what is this image? Yes, what is this image? So it will be very, very difficult to identify this image just by this. But if I say that this is an IVP image, it will be easy for you. A lot of students fumble in this. Lot of students fumble in this year NEET PG exam. So I think it will be helpful for you if you just pay attention to this. So please remember, if you see so much white on a radiograph, remember the simple rule. Okay, let me just tell you a very, very interesting point about the imaging. And always try to understand the images in this. If you see a radiograph, understand this. Understand this rule. If you see a radiograph and you see something very white, can you tell me what it could be? It could be either bone or stone. It could be either bone or stone. Bone, you already know where is the bone. If it is not at the anatomical location, then it should be stone. Now, I will divide stone into two groups. Either it's a proper stone or it's a calcification. Either it's a proper stone or it's a calcification. What is the difference between stone and calcification? Stone will be present in a lumen. Calcification will be present in parenchyma. Stone is present in the lumen. Calcification is present in parenchyma. Stone is present in the lumen. Calcification is present in the parenchyma. Okay. What will you see in ureter? Stone. What will you see in liver? Calcification. What will you see in gallbladder? Stone. What will you see in pancreatic duct? Stone. What will you see in pancreatic parenchyma? Calcification. Okay. Please remember, all this will be if there is a radiograph. However, if it's a contrast study, mind my words, if it's a contrast study, what is a contrast study? When an external contrast is given, like IVP, MCU, RGU, HSG. When a contrast study is given and you see very, very white, please remember it will be either bone or contrast. Then it will be either bone or contrast. Please remember, as a rule, for a contrast study, examiner will not show you a stone or a calcification. For a contrast study, the examiner will not show you a stone or calcification. Please do not mix this. It was very painful to see that the students did this wrong in the NEET PG exam. It's a simple concept of the imaging. Very, very simple concept of the imaging. I felt bad when I saw the students did not see it. If they would have attended just 10 minutes of my uroradiology, either in the live class or in the eGurukul, they would not have committed this particular mistake. Okay, but anyways, whatever has gone. Please make sure you don't do this mistake in the future. If it's a contrast study, examiner will not show you stone or calcification. The reason is contrast will also be white and stone or calcification will also be white. They will mix, and that is one of the biggest reason for every contrast study. The first study that is done is a plain study to look for calcifications or stones. In the NEET PG exam, IVP image was given. In the NEET PG exam, IVP इमेज वॉज गिवन. तो बच्चे, अगर IVP इमेज दी हुई थी तो स्टैगहॉर्न कैलकुलस नहीं हो सकता. याद रखना, if an IVP image is given, the examiner will not give you Staghorn calculus. So that means all that white that you were seeing, was contrast. All that white was contrast. And if you see this dilated pelvis filled with the contrast, you have only one answer. What is that answer? PUJ obstruction. Pelviureteric junction obstruction. Pelviureteric junction obstruction. Pelviureteric junction obstruction. Okay, so remember that. And what is this? This is a dilated ureter with its lower end much more dilated, which is called as adder head appearance, also called as cobra head appearance, which is a feature of ureterocele. Adder head appearance or a cobra head appearance, which is a feature of ureterocele. Okay. All right, so let's take this doubt, and this is probably the last important doubt that I will be taking, and that is how to select whether you should do a CT or whether you should do an MRI. Whether you should do a CT or whether you should do an MRI. So for CT, remember this simple rule. 3 types of CTs: NCCT, CECT, and HRCT. NCCT, CECT, or HRCT. Okay, when will you do NCCT? Just remember, if you have to see these 4 tissues, I would like to perform a non-contrast CT. What are these 4 tissues? Cortical bone, acute hemorrhage in brain, calculi or calcification, cortical bone, acute hemorrhage in the brain, calculi or calcification, or air. Cortical bone, acute hemorrhage in the brain, calculi or calcification, or air. If you see any of these 4 structures, always do a non-contrast CT. But just careful, cortical bone is commonly done to assess fractures. For a fracture of simple anatomy, for a fracture of simple bone, a radiograph is sufficient. A radiograph is sufficient. Okay. I hope a lot of you must have seen a video that I have shared on my Twitter, which became viral on the WhatsApp about the newer machines which have got a very portable radiographs, a digital radiography. So a lot of people were messaging me that is it a real or a fake video that I created. So please remember, those machines are available. I don't make fake videos. I don't make spoof videos. So that's a real machine that is available, and specifically for the chest x-rays, extremities x-rays, these have become very easily done and easily perform radiographies with very minimal radiation dose. Okay, so just remember, if you see these 4 structures, want to see these 4 structures, it has to be a non-contrast CT. If you want to do CT because of any other reason, do a contrast enhanced CT. Like if you want to stage a tumor, staging of a tumor, lymph node characterization, infection, inflammation, and abscesses. Infection, inflammation, and abscesses, specifically in chest and abdomen. Specifically in chest and abdomen. Staging of a tumor, lymph node characterization, infection, inflammation, and abscesses. Trauma. Please remember, most useful imaging investigation if you want to do in a trauma should be CCT, with 2 exceptions. What are these 2 exceptions? First is head trauma. In a head trauma, I would like to do non-contrast CT. The reason is, if I do a CCT, I do not know whether it's blood or dye. And second is unstable patient. In an unstable patient, I don't have a time to do a CCT, and that is why I will not do a CCT. And also remember, CT angiography is also a type of CECT. CT angiography is also a type of CECT. On the other hand, if somebody asks me HRCT, I just remember miliary TB, ILD, bronchiectasis, miliary TB, ILD, bronchiectasis, and today's scenario, very important disease, and that is COVID. ILD, bronchiectasis, miliary TB, COVID. In the chest, these are the uses of HRCT. Apart from that, HRCT is also used for temporal bone. HRCT is also used for temporal bone. Okay. Yeah. MRI. Now, please forget this point that MRI is done for soft tissue. A lot of soft tissue, lymph node characterization, staging of the tumor are done on CT. MRI is very good for neural tissue. MRI is very, very good for central spongy part of the bone. Spongy part of bone. What is that spongy part of the bone? Cancellous bone. Cancellous bone. MRI is very good for cartilage. And MRI is very good for ligaments and tendons. So if you want to see neural tissues, if you want to see cancellous part of the bone, if you want to see cartilage, or if you want to see ligaments and tendons, always do an MRI. Always do an MRI. Okay, so that is how broadly you wanna decide. Okay, alright, chalo. अब मेरे को कुछ questions के answer बताओ. Let me see who can answer it first. We will do some rapid fire on this. Anybody who can tell me investigation of choice for staging of a lung cancer. Investigation of choice for staging of lung cancer. Obviously, it has to be a CCT or a PET CT. Now the question is, anybody who can tell me which lung cancer should be staged by MRI? Which lung cancer should be staged by MRI? Answer is pan-coast tumor. The staging of the pan-coast tumor should be done by MRI. The reason is very simple, because pan-coast tumor involves neural tissue. Pan-coast tumor involves neural tissue. Okay. All right. Next. Single most important radiological investigation to diagnose a bone tumor. Single most important radiological investigation to diagnose a bone tumor. Single most important radiological investigation to diagnose a bone tumor. Answer is plain radiograph. The most useful imaging investigation to diagnose a bone tumor is a plain radiograph. Okay. Now, intraosseous extent of a skeletal tumor is best assessed by which investigation? Intraosseous extent of a skeletal tumor is best assessed by which investigation? Answer is MRI. Intraosseous extent of a skeletal tumor is best assessed by MRI. Intraosseous extent of a skeletal tumor is best assessed by MRI. Okay, and I will stop with the last question. Let me see who answers it first. Anybody who can tell me name of a bone tumor which is better seen on CT than MRI. Name of a bone tumor which is better seen on CT than MRI. Any bone tumor which is better seen on CT than MRI, and you have to give me a reason of that also. It is osteoid osteoma. Osteoid osteoma is the only bone tumor which is better seen on CT than MR. Osteoid osteoma is the only bone tumor which is better seen on CT than MRI, and the reason is very simple. The nidus of the osteoid osteoma is present in cortex. The nidus of the osteoid osteoma is present in the cortex, and that is why it is better seen on CT than MR. Okay. All right, guys. So this is a small, quick revision come doubt solving session of radiology. Okay. Please feel free to put me the doubts on my Telegram channel, or it's Rajat's Radiology Review. If you just check it, you will find it. You can put it onto the DBMCI Premier group at the Telegram. You can put it onto the Facebook group. You can put it onto the eGurukul. I will be happy to answer in the best possible way that I can. Okay.